Hello everyone, welcome to Renal Rehabilitation Laboratory. This is you, a physical therapist. This time I'd like to talk about this question. Is functional dependence associated with mortality in all ages and all countries? Although the research of these topics are increasing now, and we need to do that in more variable and bigger population. So let's learn about it. Today, I'd like to talk about this study, Functional Dependent and Mortality in the International Dialysis Outcome and Practice Pattern Study. Patients established on dialysis have amongst the highest mortality and hospitalization rates of all chronic conditions. One potential contributor may be the high burden of functional dependence. In the general geriatric literature, functional dependence is recognized as a contributor to subsequent disability, recurrent hospitalization, and increased mortality. Predictors of functional loss include age, chronic diseases, multiple comorbidities, and recurrent hospitalization. Multicenter studies have shown that CKD places patients at increased risk of functional dependence even after adjustment for the higher prevalence of predisposing comorbidities. Recent estimates suggest individuals with CKD stage 3B have a threefold increased risk of developing dependence in daily activities such as bathing, dressing, and personal care compared to individuals without renal impairment. Furthermore, there appears to be a faster rate of functional decline. However, studies in the dialysis population are limited to small single-center studies of older patients with little information of the difficulties that younger individuals report. Dialysis-related factors that may predispose to functional decline have not been characterized. In this study, they evaluated the proportion of patients across all age groups established on dialysis that reported functional dependence, questioned whether the presence of functional dependence would be associated with a higher mortality and hospitalization rate independent of clinical and demographic variables. In addition, they evaluated whether the burden of functional dependence would vary with age and across the countries participating in the dialysis outcomes and practice pattern study. Data from participants in DAPS Phase 4 from 2009 to 2011 in Australia, Belgium, Canada, France, Germany, Italy, Japan, New Zealand, Spain, Sweden, the United Kingdom, and the United States were used. Five tasks were evaluated as ADL: eating, getting dressed, bathing, using the toilet, and transferring from bed to chair. And responses of yes were squad 1. A response of no couldn't distinguish between performing a task with some help or unable to perform the task at all. Thus, A score of 0.25 was assigned rather than 0. 8 tasks were evaluated as IADL, using the telephone, getting places beyond walking distance, grocery shopping, preparing meals, doing housework or handyman work, doing laundry, taking medications, and managing money. To score individual items, IADL responses of need no help were scored 1, need some help were scored 0.5, and unable to do at all were scored 0. Functional status score was defined as the sum of the 13 item scores and ranged from 1.25 to 13. To examine the shape of the association between functional status and outcomes, functional status score was categorized into 4 groups, less than 8, from 8 to 11, from 11 to 13, equal 13. Quality of life was also associated on the patient questionnaire using the SF-12 and summarized into physical component summary score and mental component summary score. Cachexia was clinically defined as undernourished or cachectic at enrollment data. The proportion of patients who could perform each task without assistance ranged from 97% to 47%. 81% of patients reported the ability to perform the 5 ADL tasks without assistance, but only 36% of patients reported the ability to perform all 13 tasks without assistance. Japan had the highest proportion of patients with 30 points of functional status score, and the UK had the lowest. Higher functional status scores were present among younger patients, males, and non-diabetics. Fully independent patients were much younger than patients in the lowest functional status category. As expected, functionally independent patients had many indicators of better patient health status. Higher serum albumin, creatinine, phosphorus were less likely to have a catheter and had a lower prevalence of several summary comorbid conditions. Patients who responded to the functional status questions on the patient questionnaire and who were included in the analysis had generally better health status, with fewer comorbidities and lower proportion of catheter usage than sampled patients excluded from the analysis due to missing data. In adjusted analysis, these were associated with a worse functional status, low blood pressure, catheter or arterial venous graft use, and high BMI. This figure shows the mortality risk for patients interacting functional status with age. The association of functional status score with mortality appears stronger in younger patients than older patients when comparing the hazard risk, in part because the baseline mortality risk among younger patients is low. We observed a higher risk ratio but only modest absolute risk difference with comparing functional status less than 8 versus functional status is 13 in younger patients. Patients with functional status is 13 reported higher physical and mental QOL than patients with functional status less than 8. After adjustment for country and age, results were consistent across all ages. Sensitivity tests suggested results were consistent with the main analysis. The adjusted hazard risk was 1.21 for patients with functional status from 11 to 13, 1.60 for patients with functional status from 8 to 11, and 2.37 for patients with functional status less than 8 when compared to patients who were fully independent. Using data from the international DAP sample, they demonstrated that worldwide a very high proportion of dialysis patients of all ages experience difficulty with routine daily tasks and that the need for help with daily tasks was strongly associated with increased mortality. Perhaps even more striking was the observation that almost half of younger patients reported needing help with at least one ideal activity. Studies from the general population suggest that cross-cultural differences, while present, are generally relatively small. In contrast, they found that the prevalence of functional dependence differed considerably across the Gulf countries, possibly reflecting not only differences in patient characteristics and comorbidities, but also in their reporting behavior. They proposed that both cachexia and the use of a central venous catheter would be important clinical factors reflecting patients who were medically unwell and therefore at high risk of death. They also noted that there is a stronger correlation between functional status and QOL measures than between age and QOL. As the renal community shifts increasingly towards evaluating the quality of care based on patient-reported outcomes, ongoing assessment for functional status may be important. It may be appropriate to incorporate functional status as a marker of future mortality risk and QOL when assessing appropriateness of chronic diuretic care. They observed a high level of functional dependence in daily activities in dialysis patients across a wide range of age groups and countries, and they found a strong dose-response association between functional dependence and adverse clinical outcomes. It remains to be shown whether rehabilitation or interventional programs can prevent or reverse functional dependence and thereby improve patient outcomes.